Yes.
Yeah, so for those who don't know me, I'm Phoebe and I'm an advanced care planning nurse for people with learning disabilities in East London. So a bit about our team. So it's based in Tower Hamlets in East London, and we identify individuals who might be in the last year of life. And the team ensures that the nice quality standards for end-of-life care are met for individuals at the end of life on the district nursing caseload. So we literally only see people that are open to the district nurses. We ensure that people approaching end of life are offered timely and person-centred support. We facilitate ACP discussions, and we build a bridge between all services involved with the person. So thinking about like the LD team in some cases, the local hospice, which is St Joe's, and the GP. There's actually a really large population of individuals with a learning disability in Tower Hamlets. I'm actually open to the district nurses as well. And so my role within the team, I develop supportive relationships with service users, their families and carers, facilitating advanced care planning discussions. So this might include a person's understanding of their illness and prognosis, their goals and concerns, and their preferences for future care. We develop person-centred holistic care plans following assessment, and these might consider sort of the spiritual and physical, psychological, social and cultural needs. We work in partnership with specialist palliative care teams, so the local hospice, facilitate the completion of CHC fast track assessments so that urgent care and support can be accessed at the end of life. We ensure that advanced care planning wishes are recorded on CMC, which is Coordinate My Care, and shared with the wider integrated team. And actually do a lot of care coordinating at the end of life. And I also work with individuals of all ages with learning disabilities, just to make sure their health needs are met. So this might help in kind of terms in preventing early deaths. So looking at things like supporting with education around health screenings, such as breast and bowel screening, and ensuring people have had their annual health checks as well. I do see people without learning disabilities and people with autism and acquired brain injury. So it's very mixed. So improving the quality of life for individuals in the last year of their life. And having important conversations provides opportunity for individuals to take control of the care they receive in the future. It enables better planning and care provision, helping them live well by empowering independence and understanding what's important to them now and in the future. And to support this, research suggests that if an individual wishes to die at home, advanced care decisions reduces the number of in-hospital deaths and is therefore economically cost effective. So what is advanced care planning? So it's basically the process of identifying future individual wishes and preferences about how a person would like to be cared for. And it's about finding out what matters to the person and what we can do to help. It's an ongoing process which may change over time based on the person's wishes and circumstances, and it should happen after a holistic needs assessment, really, to ensure that it fully takes into account all of the things that's important to the person. And it's important that it's not a legal document, but should be considered when planning care. And it's important that everyone, including people with a learning disability, are offered opportunities to engage in advanced care planning. And even if they don't have a mental capacity to fully participate in these discussions, the person we support should still be supported to identify and share their choices about end-of-life care. And just like everyone else, being able to make choices about their current and future end-of-life care, and ensuring that those involved in end-of-life care are aware of these choices, can really help improve the quality and experience of care for the person. And so 5 steps to completing an advanced care plan. Supporting the person to think about things that have meaning to them, including sort of who they want around, looking at their values, wishes and faith, learning about what future options are available, places of care and treatment. And if the person has capacity, looking at supporting them to decide who can speak to them and who needs to be involved, thinking about lasting power of attorney, talk about any wishes and exploring any fears and hopes, and recording this and reviewing. So in London, we use Coordinate My Care, which you may or may not be aware of. It's basically an NHS service that coordinates urgent care for people and documents their advanced wishes. it enables wishes to be shared with professionals involved in somebody's care, such as the district nurses, the LD teams, or acute care, London Ambulance Service. And it's really good because you can attach documents to it. And what I like to do for the individuals I support is put their hospital passports on it as well. These coordinating my care basically ensures that everyone's in the loop with the person in the middle. And it can be accessed online by the person and their families, and they can have a hard copy in their home. And they're in the process of looking at an easy read version for that as well. So I know Sue covered a little bit about this earlier, but in practice, these are kind of the identification tools that we use to kind of prioritise individuals with learning disabilities and without, who may benefit from advanced care planning. So the SPIT tool, it has 6 general indicators of deteriorating health and clinical signs of advanced, progressive and underlying conditions, and it helps identify people for care planning. And people identified using the SPIT are at risk of deteriorating and dying, although what will happen to each person and when is often uncertain. So the question we always ask ourselves is, can we reverse it? And we can have ACP discussions at any time, but the care and treatment choices are more likely to be needed in light of changing circumstances. And those discussions are therefore triggered by certain situations. So, for example, thinking about the people we support and the general indicators of deteriorating health, looking at the number of hospital admissions they've had over the last year or two, is it increasing, or if they're becoming more dependent on others, and if they've got persistent symptoms despite optimal treatment, then you want to think about prioritising for advanced care planning. So another tool we use is the phase of illness. So this is what we use to kind of rag individuals open to the district nurses and also on our advanced care planning register. And we meet with the district nurses every 2 weeks to review these people and review their phase of illness as well, because the district nurses are the ones going in most regularly and kind of monitoring that. And this tool basically enables to ensure that people both with and without learning disabilities who are nearing the end of life receive consistent care that's coordinated effectively, and more importantly, they're identified. And we want to ensure really that we have these advanced care planning discussions whilst the person is in that stable phase, and they can still communicate for themselves, but reviewing as their health deteriorates. And early planning for care at the end of life helps to ensure that carers and families and professionals are aware of a person's wishes whilst they're still able to fully communicate them. I also wanted to touch a bit about the phase of illness for people with learning disabilities, which I think is absolutely amazing. So we know that the extent and impact of inequalities in the health of people with learning disabilities have been well documented over the years, and current research indicates that people with a learning disability are 3 times as likely to die early than the general population. They're also more likely to experience poor general health and have high levels of unmet physical and mental health needs. And identification, assessment and management of these conditions is important, but it can be challenging. So I know St Christopher's Hospice, their aim was to kind of develop resources with care staff to help them and enable them to recognise and manage changes and decline in the health of the person with the learning disabilities. And one of this was the phase of illness. So it was used in 39 care homes and empowered staff to meet people's immediate health needs, and enable care staff to recognise the signs and symptoms of each person's comorbidities early, and to identify and manage changes when their health declined. So I wanted to touch a bit about kind of each phase and what they kind of recommend. So when somebody with a learning disability is stable, they should be involved in future care planning, ensure that they have a health action plan and hospital passport in place, their communication is assessed and specific aids identified, for example, having a communication passport, an assessment of their needs in relation to their general health and well-being and comorbidities to take place. Thinking about when they're unstable, a review of their advanced wishes should take place, and consideration should be given to referral to specialist services for review such as oncology and cardiology and psychiatry, an assessment of their family's needs and other residents they're living with as well. And when somebody is deteriorating, increased proactive review should really take place by their GP, And at this point, we would consider referral to specialist palliative care services, so the local hospice, and anticipate further deterioration. I think what's really important is to ensure that end-of-life drugs are prescribed and obtained. So a big part of our role is kind of liaising with the person's GP and hospice to ensure that these end-of-life drugs are actually in place before they are needed, before it kind of hits that crisis point. And work should be done with family and friends and other residents as appropriate for the person's deterioration and health. So I think managing expectations for the person and those around them as well, and being very open about prognosis. And I do always use the term that Catherine Mannix uses when she says that, you know, they're sick enough to die. A lot of our role and my role is managing expectations for those around the person and the person themselves. So recently we sort of had a supported living home who were worried about a person's appetite and things like that when they were nearing the end of their lives. So we supported the home in sort of managing expectations and what's likely to happen at each stage and telling them that actually this is okay. I think particularly with the learning disability, the focus on is always on kind of, you know, making them better and actually recognising that kind of irreversible deterioration is so vital. So I was having to think about dying and preparation for death and preferred place. So avoidance of transfer to hospital if they wish to die at home. That's why a CMC care plan is so good, to kind of alerting the London Ambulance Service that actually this person wishes to die at home. Supporting the person, our staff supporting the person should be able to recognise, you know, the signs when a person's dying. So assessing for pain and agitation and chesty secretions and things like that, and being sort of prepared to answer the dying person's question in an open and kind of sensitive way they'll understand, and letting the family know what to expect in the final stages and providing kind of emotional and practical support. And residents and other care staff should also be informed of kind of the person's deterioration and expected death. And we also provide families and carers sort of information about what to do when somebody dies, because I actually find, particularly people living at home with their families, that people aren't often told that. And thinking about aftercare, so advice to be given to family, you know, around bereavement support, and to offer that an openness with death with other residents as appropriate, and thinking about the tools, you know, easy read tools to aid explanation, particularly people in like residential supported living homes, and the review of the care provision after death. So when should we start having these discussions? Something that I was thinking about when I first joined this team. So we can have these discussions and conversations at any time with the people we support, but the care and treatment choices are more likely to be needed in light of changing circumstances. So individuals who have a life-limiting condition or have been identified using the SPICT, but ideally an advanced care plan should be discussed to inform future care at an early stage. But due to the sensitivity of some of the issues discussed in ACP, some people might not wish to answer them all, or may quite rightly wish to review and reconsider their decisions later. And what I found actually is people are usually very open and kind of feel like it's been, you know, a weight being lifted. And although advanced care plans are often initiated when somebody's been given a life-limiting diagnosis, the ACP process can actually start a lot earlier. And I think I found it really helpful to kind of make use of those ad hoc opportunities to talk about death and dying openly with somebody with a learning disability. And I think sometimes those involved in the care of people with a learning disability kind of believe that they're protecting somebody by not including them in conversations about death and dying, whereas that's not the case. People with a learning disability, just like everyone else, should have the opportunity to participate in conversations about death and dying, as it's a normal part of life. And this can help somebody with a learning disability feel more prepared for the death of loved ones and ultimately their own death. So these are some of the discussion tools and resources that I use in practice and I wanted to share today. So the gold standard framework discussion tool, again recommended by NICE guidelines. I really like this tool and often adapt it. It's brilliant. The Easy Read Advanced Care Planning booklet, which is My Future Wishes plan. So this was actually launched in pilot across Northamptonshire. and it was funded by Health Education England. And I really like this booklet and often use it in practice. And the trust who devised it kindly sent some hard copies in the post, which can be requested by email. And it's hoped that the resource will actually prove useful to others as well who would benefit from easy read materials, such as people with dementia. One-page profiles, I'll touch on those in a second, talking maths, books beyond words. So within my role, I also support members of the family who may have a learning disability, such as somebody that's open to the district nursing caseload. So I'm working with one young man at the moment. His mum has a diagnosis of dementia and cancer. And the books beyond words is such a great resource to open up discussion. For this one, it's particularly the one about mum dying. No barriers here, which we touched on, easy on the eye, again, great resource for so many pictures. Red map, the red map framework. So it stands for ready, expect, diagnosis, matters, actions and plans. And this is basically a six-step guide to future care planning conversations with people whose health is deteriorating and their families. It helps us prepare, share information about what's important and agree goals and actions for future health and care plan. And the accessible planning tool is basically an easy read guide to help what a person would like to happen at the end of life. And it supports somebody to think, talk and write down and review the care and treatment they would like at the end of life. So one-page profiles, I really like using these. They provide us with an at-a-glance way of knowing what really matters to people. And these can be taken with people as they move through services and come into contact with people. It captures all the important information about a person on a single sheet of paper and can also be used to start up conversations, thinking about what's important to somebody and how they want to be supported. And it's important that they're regularly updated to reflect people's changing circumstances and goals for care. And Helen Sanderson Associates have some brilliant one-page profiles on their website. This is where I got these from. And examples of what one-page profiles look like at the end of life as well. So they've got some examples on there too. So usually I find it better to kind of pull together lots of different resources. So this was a lady that I saw recently. I used the Easy on the Eyes image bank because I've got so many different images on there. And I also bought some blank pieces of squared paper. This lady absolutely loved drawing and colouring, so she could draw and colour sort of what's important to her, which worked really, really well. I used the Talking Maps top scale, which is really useful to establish views of an individual as kind of like an interactive exercise as well. So the ones I usually like using for advanced care planning discussions is very important, quite important and not important, and like, unsure and dislike. And this lady didn't actually have a life-limiting condition as such, but I spent time building a relationship with her, and she was very open to discussing her advanced wishes as well. I also wanted to cover a little bit about best practice, thinking about the care and support of people growing older with learning disabilities, guidelines, recommendations. So asking the person regularly who they would like to have involved in discussions about their advanced care plan in case they change their mind. It's recommended that we do this every 6 months or more often if a person is close to the end of life. Making sure that the key members of the person's support network have the knowledge, confidence and understanding to communicate with the person about their illness and death. So this might include being able to talk to somebody about their symptoms, pain management, preferences about resuscitation. A lot of our role is around managing expectations for the person with a learning disability and their support network about their condition as well. Making it possible for the person to die where they wish. So this might include thinking about adapting their home, working with other practitioners and advocates, and talking to other residents or family members about changes that could be made. So, for example, moving the person to the room on the ground floor, and practitioners providing end-of-life care spend time getting to know the person and understand their health needs. So this might include how they communicate, their cultural background, what they like and dislike, how they express pain, their health conditions and the medication they're taking. And this understanding will make it easier to identify when the person's health is deteriorating. And here it might be useful to think about what tools might be helpful, such as a distaff to help identify when a person's in pain or distress, and making reasonable adjustments to people's homes as they grow older to make it possible for them to stay in their current home if they want to. So consider a phone support line, daily living equipment, telehealth monitoring, home adaptation, such as, a wider shower room conversion or lift between floors. I think it's really important to discuss with the provider of someone's home in terms of planning ahead and what adjustments can be made to allow the person to continue living there. So from my experience in working in sort of some supported living homes, is they're not always kind of equipped to, sort of deal with someone at end of life, really. And so having those conversations early and look at actually what adjustments can be put in place is really important. And just a bit more about best practice, thinking about the end of life care for adults guideline. So ensuring that service providers should develop policies to ensure that ACP is offered to adults who are approaching the end of their life, and policies should sort of take into account vulnerable groups such as people with a learning disability. Repeat assessments of some of these holistic needs and reviews of their advanced care plans should take place when needed. And providers should have systems in place to ensure that individuals have a copy of their advanced care plan in their place of residence or with them if admitted to hospital, care home or hospice. So I've got a couple of case studies now, just about people that I've worked with since starting in this role in June. So the first one is Mr. K. So he had a diagnosis of a mild learning disability, lung cancer, which had spread, and schizophrenia. He resided in a supported living home and he had two brothers who were really involved in his care. And he was under the district nursing team for wound management. And as you can see, there was lots of people involved in his care. And we use a lot of easy read resources to support with ACP discussions, thinking about some of the tools that I spoke about earlier to help identify what his wishes were and what's important to him. And actually, he expressed the wish to be cared for at home and to ultimately die there, but it was really important to him to have his brothers with him. He wanted to see a priest, so we did some work with the hospice and referred to their chaplaincy service. And we did a lot of kind of care coordination for him, facilitated some joint working between services, managed expectations for Mr. K himself, his family and the staff supporting him, sort of things to look out for and what to do after the death. We had professionals meeting with Mr. K himself. We did a CMC together, and he wanted his family to also access this, and we reviewed that together as well. We did a fast track application, which was approved, and we did some joint working with the GP as well, who was amazing. Used an easy read sheet to discuss DNA CPR with Mr. K and his family, and supported kind of ordering equipment prior to the deterioration to anticipate. And he did actually die at home in the presence of his brothers. In this case, he wanted to stay at his accommodation, and we needed to look about what adjustments could be put in place to kind of allow him to stay there. So this provider, they weren't able to provide certain aspects of care kind of as per their policy. So the CHG fast track that was completed allowed an additional care package within the home to provide care that they weren't able to do. So things like personal care and assistance with eating and drinking and repositioning, things like that. And we offered bereavement support with the family. And we did help the family and carers sort of understand what will happen at each stage in terms of dying. And this sort of it's allowed his supporting staff team to know when to call his brothers as well. And they were able to spend his final hours with him, which was really important to Mr. K. So Mrs. H, she has a mild learning disability. Some other comorbidities such as ischemic heart disease, COPD, and type 2 diabetes. Again, she had quite a lot of professionals involved in her care. She had multiple long-term irreversible health conditions. She lives alone, but she's got a support package in place. And she's under the care of the district nurses for diabetic monitoring. She was bedbound following a fall as well a couple of years ago. So she was very open to discussing her advanced wishes, and I spent quite a lot of time kind of getting to know her, did some joint working with the district nurses as well. And it was really important to her to improve her quality of life, so engaging with physio to get her out of bed. So did a lot of joint working with the physio, which was fantastic. Her family and her flat, very important for her. It's also really important for her to be cared for and to ultimately die at home. And her preference was to have a DNA CPR in place, and she was very consistent with her view around this. So undertook sort of a holistic assessment of her needs, devised a hospital passport and ensured that she had a health action plan in place, facilitated ACP discussions, did this kind of using sort of easy read in that booklet, joint working with the GP regarding DNA CPR, carrying out mental capacity assessments. The GP was amazing, and provided education and support around health screening as well. We looked at devising a CMC care plan together and reviewed this regularly with Mrs. H and her family, ensuring that she had a copy at home as well. Lastly, Mrs. C, so she has a diagnosis of severe learning disability, Down syndrome, dementia and chronic kidney disease. She had always lived at home with her family, an extended family, her whole life, and she was sort of very happy, very comfortable there. Dementia was diagnosed in 2019. Sort of mental capacity assessment concluded that she kind of lacked the capacity to engage in ACP discussions. Her first spoken language was Bengali, and she was non-verbal. So again, undertook sort of assessment of needs. We had completed a DISTAT with her support network to sort of help identify when she sort of presents in possible pain and distress, which was shared with the wider MDT and family, such as district nurses, and helping them to recognise when she might be in distress as well. Ensuring that an interpreter was always there for home visits and meeting with family. And sort of ACP discussions took place with her family and under her best interest, and they were a great advocate for her, they really were, and it was agreed that it was in her best interest to be cared for and to ultimately die at home. I think she had lots of fears around her hospital in the past and things like that. Discuss sort of DNA CPR with family and GP, kind of understanding sort of the rationale for this, and to kind of allow natural expected death in the community, and manage expectations to the family with regards to kind of deterioration as well in terms of dementia, which the SPIT tool sort of supported. Again, quite a lot of coordinating, attending sort of a number of best interest meetings around her accommodation and health needs, fast track and supported with religious and spiritual needs, so liaise with the East London Mosque and the Imam there. So yes, I just included some references as well. There's some links to some of the tools that I've used and the one-page profiles that I find really helpful. I just wanted to share. So I hope you enjoyed.
Thank you, Phoebe. That's really kind and really useful, and sets up quite nicely for some of the work that we'll do after the break.